Hello, my name is Professor Ravi Gupta. I'm a professor of clinical microbiology at the University of Cambridge, and I'm going to be speaking today about variants and vaccines. Here are my disclosures. So SARS-CoV-2 has been estimated to have a mutation rate of around 2 per month, and this is related to the short incubation period, asymptomatic transmission, and rapid infection of cells in what we call a hit and run sort of approach to infection. And all of these have contributed to a relatively low selection pressure because by the time the adaptive immune system has kicked in, the virus has already spread to another host. So there's little opportunity really for adaptation in most individuals. However, this paradigm was turned on its head in the middle of last year by the definition and reporting of a number of cases of chronic SARS-CoV-2 infection and the emergence of variants with large numbers of mutations. So it was realized that chronic infection was happening with SARS-CoV-2, with people shedding virus over prolonged periods. And it was noted that these individuals were often immune suppressed or taking immune suppressive therapy. And we reported one of the initial cases shown here in an individual in his 70s who had a history of lymphoma and who presented, unfortunately, with coronavirus infection that lasted something like 4 months and ultimately was fatal. Now, our patient was treated with rituximab for a relapse of his lymphoma. And had been treated with a whole host of chemotherapeutic drugs in the past. So his immune system was dysfunctional, both on T cell and B cell arms. And the chronic infection persisted with relatively low CT values, indicating viral replication that was continuing. And you can see here in the right-hand figure some of the treatments that were administered. After a month, we started wondering whether we should treat this individual. We used remdesivir for 10 days, which didn't have much effect. And then a second course of remdesivir along with convalescent plasma given as 2 consecutive units on 2 consecutive days. You can see that the CT value, in fact, proceeded to fall after that, so there was no clear response. But what happened, as you can see here, the triangles here are showing you the proportion of virus variants in the nasopharyngeal samples that were taken, and 100% indicates that all the virus in that particular sample had a mutation, and 0% was, of course, wild type. And here we're focusing on spike, and you can see a viral variant emerged with mutations D796H and the Delta 6970 mutation after the first course of convalescent plasma. And after a couple of weeks, that declined, consistent with the loss of convalescent plasma pressure, and 2 other sets of mutants arose, bearing mutations at 240 and 200, and then another set of mutants at 330 and 64. Now, what was remarkable is that during this period, we decided to try a 3rd course of remdesivir because of declining condition, and combined with a 3rd course of convalescent plasma. And what we saw is that initial population of viruses re-emerged, the 6970 deletion plus D796H, and both of these mutations are now seen in globally circulating lineages. So what we had observed here was the evolution in real time of virus variants and spike. We then popped these into a phylogenetic tree on the left, and you can see that there is a relatively high degree of divergence over those samples and distinct virus populations emerging. So what we've achieved here is to describe really for the first time the dynamics of virus variants, first of all, intra-host, within the host, in response to different therapies, namely, we believe the convalescent plasma, which you can see here from day 82. You can see emergence of multiple linked mutations, which tells you that virus haplotypes are in competition with each other, and some are dominating over others. And you can see this is very, very fluctuant because there was treatments were changed relatively frequently. So this brings us on to variants of concern. So I've shown you really the blueprint of how we believe it happens. It's intra-host evolution, potentially driven by things like plasma or even just residual immunity in the individual during chronic infection. But the result is a multiply mutated virus. And B117, or the alpha variant, was the first to emerge in the UK. Very soon after, in fact, we reported or studied the patient I've just described. And this remarkably had the Delta 6970 deletion, which we were already observing in our individual. But the alpha variant also had a number of other mutations, as you can see, N501Y. That is also a key mutation seen in other variants of concern. You can see here the beta and gamma, usually in the RBD associated with mutations at position 484 and 417. But the alpha variant really only had the 501Y in combination with a major deletion in the NTD, the Y144, that's quite common now in other variants, as well as a number of mutations in the S2 domain. So let's start with the alpha variant. What did that mean for vaccines? Well, here are some data from two groups, including our own, showing you that following vaccination with either the Moderna, Novavax vaccine, or in convalescence, you can see that the B117 virus showed reduced sensitivity to vaccine-elicited sera by about twofold. And on the right, you can see data from our own group mirroring some of this information. We also observed a twofold loss of efficacy of neutralizing antibodies from Pfizer vaccine sera. So this was a subtle effect, and which was very reassuring at the time because there was a lot of fear, as you may remember. The data on the bottom panel show you that a panel of neutralizing antibodies against the NTD were quite significantly impacted. So that's interesting because many people make significant NTD directed antibodies, but these overall didn't have a large effect on vaccine efficacy, certainly in vitro. So what about in the clinic? Here's some data from a number of vaccines. And in general, you can see here that there is very high efficacy of current vaccines against the alpha variant, or B117, which was very reassuring and has led to high levels of control of B117 transmission in a number of settings. Moving on now to the beta variant, the B1.351, which emerged in South Africa. This virus has caused concern because it has the E484K mutation in combination with K417 mutation and 501Y. And you can see here in data from colleagues in South Africa that the beta variant shows markedly reduced susceptibility to neutralizing antibodies that are elicited following a previous infection with a more ancestral strain, the Wuhan plus D614G, and that you get a difference in the degree of cross-protection between different variants depending on which your initiating strain was. When we now look at protection against B1.351 or the beta variant and the P1 variant or gamma following vaccination, you can see that for Pfizer and Moderna mRNA vaccines, that the virus with the least susceptibility is, of course, the beta variant. You can see in the red bars. The P1 has intermediate susceptibility, and as I showed you before, the B117 is relatively sensitive to vaccine-elicited antibodies. So these are the sort of standard data that a number of labs have reported around the world, and this fits nicely with the vaccine efficacy that's been observed against the beta variant. You can see here for the mRNA vaccines and the adenovirus-vectored vaccines that there is, in particular for the adenovirus-vectored vaccines, a drop-off, in particular for ChAdOx1 in clinical infection. But of course, you must remember that the ChAdOx1 trials or studies did include infection, in asymptomatic infection, and bringing the efficacy down to 10%. There were other studies did not screen for asymptomatic infection, and their estimates are based on symptomatic infection, hence the difference that you see here. So we can see that for the beta variant, there is a drop-off in vaccine efficacy. Importantly, the protection against severe disease and death was extremely high across all vaccine platforms, and that's an important take-home message here. For the P1 variant or the gamma variant, we have very little data except for the CoronaVac, where the efficacy was something like sort of in the 60s. So we need more data for the gamma variant. So these data from the clinic and in vitro studies come nicely together in this paper published very recently in Nature Medicine, where they try to get towards a correlative of protection. And here they've plotted the neutralizing potency in sera from people vaccinated, comparing it to convalescent sera for particular viruses. And you can see that there seems to be a relationship between the observed potency of neutralizing antibodies observed in sera and clinical vaccine efficacy in the field. And this is only one of a number of strands of evidence that do point towards neutralizing antibodies being a very strong correlative of protection from infection, though of course we know that severe disease and death may be regulated, or other factors such as CD4 T cells or CD8 T cells may play a role in protection from severe disease. So the correlative protection here seems to be neutralizing antibodies for infection per se. Some important observations that we and others have made on the impact of age. You can see here that after the age of 80, there is a significant drop-off in the ability to neutralize SARS-CoV-2 pseudotyped virus particles. And these are data using the Pfizer mRNA vaccine. And when you start testing different virus variants against sera in the elderly, you can see that the proportion of individuals with no neutralizing activity goes up as you use virus variants with more and more mutations associated with escape. So this is essentially telling us that after the first dose, we must remember that elderly individuals may be more at risk of infection and disease compared to their younger counterparts. Now, when you have the second dose, many of these differences disappear, but we should bear in mind that drop-off in responses is likely to be faster in the elderly. So we do need to treat this group with special care. So moving on to the Delta variant, this is obviously the most important variant currently because it's spreading in a number of different areas. This phylogenetic tree shows you the three different lineages. The one we're going to focus on is the 617.2, which is the Delta variant. And on the right, you can see the proportion of sequences in GISAID from India that have that are represented by the Delta variant in green, and you can see that's completely taken over from other lineages that were circulating in India over the last few months. If I showed you the data from the UK, it would be a similar story. So we first wanted to know whether the Delta variant was more infectious to explain its faster spread. So we used airway organoid models of infection. We used live Delta virus, and we infected those cells. And we can see here in the green bars, higher infectivity observed in comparison to the B117 or alpha variant. We then went on to observe in healthcare workers vaccinated with ChAdOx1 in India that in a number of cases we were finding that of course, we expected there to be a preponderance of Delta infections in the hospitals, but we found that the Delta variant was associated with much bigger clusters. And here you can see an example of 10 different individuals infected almost clonally during a particular super spreader event potentially, whereas the other variants have only associated with one or two linked infections. So we can see from this that there is a possibility that transmission in vaccinated individuals is a distinct possibility, and transmission between vaccinated individuals could potentially be happening. Well, why is that happening? Well, here we can show you some evidence of immune evasion from vaccine-elicited neutralizing antibodies using live virus against individuals vaccinated by Pfizer and AstraZeneca. And you can see here that there's an 8- or 9-fold loss of sensitivity of the Delta variant, and that could explain why we're seeing breakthrough infections in the healthcare workers. So to conclude, the Alpha variant shows modestly reduced susceptibility to vaccine-elicited antibodies, but in the real world, efficacy is very high, probably because antibodies are generated against numerous different epitopes, and of course, they are outside the spike protein in combination with T-cell immunity. The Beta variant shows the highest degree of immune escape. The Gamma is intermediate, And of course, we should now be worried about Delta, not only because it's more infectious in vitro and spreading faster, but also because it has significant immune escape potential. And we should be cautious in the elderly about extending dosing schedules because they are left vulnerable after the first dose. In future, we need to know which vaccines should be developed, what the mutations should be in those vaccines. We need to ensure equitable access, of course, to stop transmission and to limit the emergence of new variants. We need to understand how to do boosting and to measure proportional protection to know who needs boosting and when. And of course, finally, we need to dissect the roles of different arms of the immune system that may involve animal studies. I'd like to thank the following individuals on this slide, and I'd like to open the floor for questions. Thank you very much.